Well, thank you all for coming. So, if there ever was an anomaly that defined pediatric neurosurgery, it's this one, it's spina bifida. And spina bifida, passes many lifelong challenges. As a neurosurgeon, we get some problems, diagnostics, pregnancy prevention, developmental disability, John Doe legislation, clinical studies, complex science, technical challenges. So it's really a fellowship just on spina bifida. We'll do a historical overview, a little bit of embryology and anatomy. Then I'll talk about the paradigm shifts that happened in our field over the past maybe 5 decades that changed the way we do things, outcomes. A little bit about the science and the prevention measures that we have, and I'll end with present challenges and future prospects. So, although descriptions of spina bifida date back thousands of years, it's really Nicholas Paul, who was the official anatomist and mayor of Amsterdam, pictured in this Rembrandt painting, who first used the term spina bifida. But in the late 1700s, Benjamin Bell was a physician that declared that spina bifida is the most fatal disease in infancy because of unavailability of treatment. So most patients died of either hydrocephalus or infection. So in other words, surgery wasn't really successful until aseptic technique was introduced in 1870s, and then later introduction of the shunt. So the earliest formal description of the myelomeningocele repair really was done by Fraser with a technique that is multi-layered, and it was successful because of the introduction of aseptic techniques, and it's a technique that we still use today. So not a lot changed there. So first and foremost, it's important to know that neural tube defects are not limited to spinal. Okay, so if it's cranial, it's anencephaly. If it's spinal, it's spina bifida. And if it's both, craniorachisthesis. It's the entire neuroaxis that's involved. So if you look at the neurulation, how neurulation happened, this is a xenopus model. Let's see if I can make the video work. Okay, so look at this. This is the actual neurulation taking place in the xenopus, and look at the defect that results from it. That's what spina bifida is. Okay. So here's what the myelomeningocele looks like in cross-section. You can see the epithelial membrane here, the placode, and it's called placode because it hasn't rolled into a tube. So this is not the dorsal aspect of the cord. This is the inside of the cord. This is what would have been the spinal canal. And these are the dorsal rootlets and the ventral rootlets. So the first thing you do is, unless this during delivery and it leaves, there is a fluid-filled pocket that you see, which the moment you enter, the fluid leaks out, and you end up with a placode and the prayer. And what we do is we bring the tissues together, including the dura, which is right here, and then skin and oftentimes fascia. And that's what a closure is. Now, here are examples of such repairs. I find that the subcuticular closure has really messed in my hands with these because you don't damage the skin when you use a running suture or use vertical mattress. Less chance of skin necrosis. The technique that I use, and there are many others out there, is really a technique that was introduced by a plastic surgeon in the 1960s or 70s. And it's a myocutaneous flap technique that brings in not just the skin, but skin and muscle right to the midline to cover the defect. And the advantage of this is that if you look at the latissimus dorsi and the gluteus muscles, they're getting vascular supply from either one or two arterial pedicles that come laterally through the belly of the muscle, which means that if you undermine the muscle, you're not going to devascularize it. So you can actually go all the way around the wall under latissimus and the gluteus and bring the entire segment together so that you're not, your closure is not all dependent on skin because that necrosis. And the other thing is if you know the vascular supply of the skin is coming from below, from the fascia. So by undermining the skin, by definition, you're devascularizing. So this is the advantage of this technique. So I started doing this based on, we did a cadaver when I was a fellow and found that this is a really good technique, and we were doing it on big myelomeningocele, and now I use it on most myelomeningocele because it's been so practical. And that's what it looks like. So there were several paradigm shifts that happened over the past few decades. And the first one was what's called a no selection. So there was this pediatrician in Sheffield, in England, who introduced the term selection and said, and that was in the 1980s, that because of disappointing long-term results of spina bifida patients, he said we need to do non-surgical care for the severe malformation. So anything higher than a lower lumbar, anything that doesn't have that has hydrocephalus, you shouldn't treat them. And other neurosurgeons followed suit, including some in the United States. However, selective treatment was met with great disapproval in the nascent pediatric neurosurgery community in the US, where they were starting to form, or North America, I have to say, because Canada is involved, but they started to form a group called the American Society of Pediatric Neurosurgeons, which led by David McClone, started showing data that if you don't operate on these kids, they're not necessarily going to die. What's going to happen, they're going to have more neurological deficits over time. And so you're not doing them a favor, you're actually doing them a disfavor, not operating. So, and I spoke with Dr. McClone about this last year, and I asked him about Lorber. He said that at one conference where he presented the data to Lorber called him a liar to his face, but he said we remain friends. So just so. So the second, as no selection was taking place in England, in the US, there was a wave of baby door legislations that came out, and it's really worth, just talking for a minute about this. So the Surgeon General of the time, C. Everett Koop, and President Reagan came together and determined that the life of a disabled child should only be withheld under three conditions, three circumstances. And these legislations are still ongoing, by the way, including Wisconsin. So one is coma and persistent vegetative state, to be exact. The other is terminal illness and the provision that such treatment would only prolong suffering. And the third one is when treatment is futile in need. Okay? So you can imagine the problems that hospitals and physicians and families are going to have with this. So the Surgeon General actually made it a point to use Jane Doe, who was a spina bifida patient, as the perfect example of this. And the law was signed by President Reagan as an amendment to the Child Abuse Prevention and Treatment Act, which was exceedingly unpopular in the medical community, and it was met with great dismay, really, by all the medical association. So the American Academy of Pediatrics, for example, came out and said, rather than follow strict legal rulings, we're going to recommend a procedural approach that is really handled by the ethics committees. And this is where ethics committees started in hospitals and started to help physicians and families with these issues. And what the EAP acknowledged is that the baby Doe rules exist, but it maintains that the inclusion should be, quote, in the treating physician's best judgment, best clinical judgment. So they gave the physician and the families really the prerogative of doing what they need to do within the constraints of this law. And so, the main reason why they were successful is that those rules don't really apply to physicians or families, but they really apply to health departments. So, anyway, regardless, although these controversies continue to date and various medical scenarios, those rarely include the care of the newborn with spina bifida, with universal agreement that these children should be treated unless, of course, they're accompanied by other major anomalies such as fatal cardiac. So that's where it's. Okay, so the first really clinical paradigm shift is the introduction of the shunt, or more specifically, the valve. Shunts, there were iterations of shunts much earlier than this, but the valve was introduced by the father of a child with spina bifida, John Holter. And if you've heard of the Spitz-Holter valve, that's the first differential pressure valve made, because John Holter went to Dr. Spitz and said, "What are you going to do for my child?" He said, "There's nothing to do. I cannot really give you a treatment that's going to control the amount of spinal fluid that is going to drain." So he went to his garage and put together a valve that was made of silicone. And prior to that, silicone had never been implanted in the human body. It was only used on airplanes. And this is our first valve. The good news is that the same technology that was introduced in the 1950s is still applicable now. We're still using valves that were designed in the 1950s, whereas everything else in the world is advanced. So the impact of this did not help Casey, John Holter's son, who died soon after. However, it impacted the whole populations of hydrocephalics, where prior to this, less than 10% survived till age 10, whereas after this, the vast majority survived into adulthood. So the second shift in our understanding is understanding progression. What does progression mean? What we talked about earlier during the break is that if someone presents with Chiari symptoms, for example, you have to look at the shunt first. And what we understand now is that these anomalies, which are hydrocephalus, Chiari-2 malformation, syringomyelia, and a tethered spinal cord from scar tissue, interact and they cause very similar symptomatology across the board. You can have a headache from a tethered spinal cord. You can have leg weakness from shunt malfunction. So they're very difficult to separate. And this is not multiple sclerosis. It's not progressive spasticity. It's not a disease that is supposed to progress over time. If you see progression, there is a clinical problem that probably requires surgery. The added problem with this is that even medical conditions can masquerade as surgical symptoms. And if most of you were here last week when we admitted a child with ventriculomegaly and progressive neurological decline. He ended up having a UTI. We treated the UTI. 2 days later, the ventricles came down in size. So you can see the complicated nature of what we have to go through to take care of these kids. And this is why, as I think Raheel told me one time, we are like pediatricians. We're like primary caregivers for these patients because we understand, the entire picture. We have to understand the entire picture to be able to determine whether that person needs surgery or not. Okay. Whether you believe it or not, a huge paradigm shift in spina bifida care is the introduction of clean intermittent catheterization. Prior to that, all these kids were completely incompetent. They were diapers, they smelled, they had UTIs. It was a very difficult social issue, if not medical issue. With this, not only are they socially continent now because they cath just like we go to the bathroom, but also they started to prevent renal injury, hydronephrosis, renal failure in these kids, and some of these kids are born with one kidney because of their caudal problems. So major issue. The second is prevention, folic acid. And I'll tell you a little bit more about this later under science, but the bottom line is that this revolutionized the field of neurotube defects because folate supplementation decreased the chance of having a spinal bifida patient or neurotube defect patient, including anencephaly, by 70% in both first-time occurrence as well as recurrence. And so it's a huge deal. It's probably the most important, one of the most important advances in neurogenetics in the past few decades. So, of course, it's important to know that neurulation happens in the first month of gestation. We don't find out someone is pregnant until the second month. So that means that the CDC recommendation is any woman of childbearing age who is sexually active should be on folic acid. Because as you may know, 50% of pregnancies aren't planned. Doesn't mean you don't want it, just means it may not be exactly when you planned it. And so it's important that you be preventative here. And of course, in the past couple of decades, people have said, well, it's difficult, especially in the developing world, to give pills, oral supplementation to people. So this is when they started to fortify grain. Now people are pushing to fortify salt. So there are lots of efforts that are going on, and now led by a few pediatric neurosurgeons as well. So third, ETV-CPC. So CPC is choroid plexus coagulation. So I've done CPCs ever since I've been here for hydranencephaly. That's the way we treat hydranencephaly instead of shunting them. But Ben Ward was a pediatric neurosurgeon that actually worked with Dr. Dempsey in Kentucky, then went to Uganda on a mission, lasted 6 years. And he started looking at these African kids and having nightmares about shunting them, and then figuring out what's going to happen if these shunts are going to fail. So he asked for another technique, and it was actually Leland Albright that went and taught him to do an ETV. And then over time, he realized that if you coagulate the choroid plexus, it actually significantly improves ETV success in infants under a year of age, usually under 6 months of age. So first he started it in the STOP study, and most of the infants he saw primarily post-infectious hydrocephalus, which is what you see in Africa. But then they did a special prospective study just for spina bifida and found 70% success. Now, this has yet to be really put into evidence in the United States or in the Western world. And there's currently a clinical trial, a big NIH clinical trial that is ongoing to test whether ETV-CPC is really successful and outside of East Africa. So the third one is the MOMS trial, fetal repair, which we had a visiting professor just a few months ago, Jay Wellens, who talked in detail about this. But just to rehash, the bottom line is that there were strict criteria to develop this NIH study that was actually interrupted because the fetal group did so much better than the postnatal group. So there were strict criteria: age over 18, low BMI, the gestational age between 19 and 26, and normal karyotype. Now you can imagine that many of the families we see don't fit these criteria. So the question is, does this apply to the general population? But the bottom line is that they cut down the chance of hydrocephalus by half, the chance of a Chiari malformation by a significant extent, and in exchange, there were obviously a few complications, especially early on, with premature rupture of membranes, uterine ruptures, premature births. I mean, what's worse than a spina bifida baby is a spina bifida baby was premature, and there was a higher incidence of death, of course. But the benefits far outweigh the risk, and the techniques now have been improved so that these risks are much less. So. 5 years later, there were secondary studies where they took the population of patients that were in the mom's trial and retested them when they were school age. And they found that the prenatal repair results held true. The hydrocephalus was much decreased, the ARIA was much decreased, better mobility. But then they also found that there was better neurophysiological test scores, I think because of better hydrocephalus, and better independent function. So they're left. As you all know, we've done our first myelomeningeal repair a month ago by Raheel, and now we have a fetal diagnostic and treatment center that hopefully will be, a top-notch center. Apparently, the case went extremely well. I was out of the country at the time. What are the questions and limitations that remain? Will the benefits of prenatal repair be durable? So far, they seem to be. Will the mom's trial be replicated despite that the criteria have been relaxed? Now there are improvements in the fetal surgery techniques. I mean, we keep improving our surgery. Now a lot of people are starting to get into fetoscopic techniques, go the scope and do the repair then. What if we try to do these much earlier in life? Would that allow us to actually repair the defect, not just cover it? Imagine if we were to be able to put a seal on the myelomeningeal at 9 weeks in gestation, the moment it forms. Would that repair the actual spinal cord? And these are questions that remain, but it's impossible to do a randomized clinical trial for each one of these changes, which means that we're going to have to rely on our best judgment in the future as to what works better. And how costly would these interventions be? Can we do them in the developing world? And that's a question. So what is the current state of affairs? Well, the majority of these kids are within normal IQ range. Half of them or more are ambulatory, half are in regular classes, and half are independent. There's the other half, of course, and these are our challenges currently. Okay, so the current challenges for us: multiple shunt malfunctions, multiple tether cord releases, leg function that ensues that, psychosocial issues and independence. We need to improve prevention. 70% is not good enough. We need 100%. And of course, some of these kids still die. They die in their sleep because of shunt malfunction. They die because of lower cranial nerve problems from the Chiari, medullary dysfunction, etc. This is Paul Nansky, who was 16, died of an obstruction in his trachea from aspiration just a few years ago. So just quickly, what we've introduced to the field ourselves, we've shown through our research that shunt death can be prevented through education, through having nurses in the office call patients and educate them on the issues related to a shunt and how to call and when to call. We've introduced the quick brain MRI technique, which is now, with the help of Howard Rowley, which is now the first line study all over the world, especially in the high income and middle income countries. We've shown that ventricle size doesn't change, so you can't really rely on the CT or the MRI every time. And at the time when we published this paper, it was 30%, now it's up to 50%. And our latest study, thanks to Mark and Joyce and others, that overdrainage, chronic overdrainage seems to be the main driver of shunt obstructions. And when we started placing anti-siphoning device in our shunt systems, we cut down the shunt obstruction rates by 60 to 80%. So what are the current non-neurosurgical management challenges? We don't know how to interpret CMGs, for example, for bladder function. We don't know how bladder function communicates with an injured, damaged spinal cord. That's something that we still need to look into. A lot of the families that were surveyed say that bowel problems are their second most important challenge. Okay. Of course, independence is key, and there are lots of orthopedic issues from scoliosis to foot deformities that we still don't have a full control over. Neurosurgically, what are the indications for prenatal repair in specific patient populations? Again, fetoscopic versus open, ETV CPC versus shunt, recurrent tether cord, how to manage 32 malformations, etc. So, what about the science? So, if you think the clinical scenario is complex, science is even more so. So, I'll give you just a bird's eye view of some of these areas of research, and then we'll, of course, I'll answer questions at the end. So, the first thing we need to know is that spina bifida is familial; it's inherited, but there's never been a gene that has been associated with this inheritance. So, in addition, there are environmental factors that are very important with spina bifida, including diabetes, certain anticonvulsants, heat, so lots of different environmental issues are involved. And oftentimes, with endemic families, you find that the risk moves with them to another location and then goes away after a few years. So the main challenge is that no gene mutation consistently predicts neural tube defects in humans, and there's not one gene that defines neural tube defects. The second is that there is no mouse model that has consistently reproduced human neural tube defects. You have many mouse models, but none of them is truly predictive. But I think most importantly, really, is that 30% of NTDs are resistant to folate. In fact, there are mouse models that are folate resistant, and there are mouse models that force folate sensitive. So it's not like if you give a higher dose of folate, you're going to take the rest of the 30%. No, there's something completely different that we don't understand yet. People have looked at inositol, and they have really good animal studies showing effectiveness, but that hasn't really translated to humans yet. So, how about folate? How much do we know about how much to give? We don't know. The 0.4 milligram dose that is used is based on one animal study using one dose. That's it. So we don't have any idea if higher doses, excess folate, can be harmful. If lower doses could be just as effective, we don't know. What you need to know about folic acid is that it's a synthetic molecule. It's not biologically relevant, really. So, which means that it needs to be converted in the body, the active folate, by an enzyme called dihydrofolate reductase, DHFR. DHFR there's so much DHFR in the liver, and so oftentimes if you give too much folic acid, it's going to stay behind, and it could potentially cause harm. So, what do we know about excess folate then? Well, there were many papers that came about in the 1980s primarily that started to talk about folic acid increasing risk of autism. And the reason they did this is because the rise in autism coincided temporarily with the introduction of folate supplementation. But then, of course, years later, other articles came out that showed the exact opposite, is that folic acid reduces the incidence of autism. And that's why it's really important that when we read the literature, we're very, very careful about assessing the level of evidence that is being shown. The other thing is folate antibodies. So there are folate antibodies that occur, autoimmune, that some people have associated with certain problems such as autism. And again, this remains controversial. There's no real, good article that shows one way or the other whether this association is real or not. And the third one is that de novo mutations are found to occur in both folate deficient animals as well as animals with high folate levels. So If you're deficient, you have de novo mutations. If you have really high folate levels, de novo mutations. So it's a Goldilocks. Again, it takes us back to what we talk about this biphasic curve, that too much is too bad, too little is too bad, and it's unlike what West may suggest, that too much of a good thing it may not be wonderful. So this is the father of pharmacology. His name is Paracelsus, and he said that all things are poison, nothing is without poison, and only the dose permits something not to be poisonous, which means you give enough of any medicine and you're going to have harmful effects. So there are various studies that show dose response of folate, but really the only significant one is our own in axonal regeneration, that shows that there is a biphasic response curve to folate that optimizes at a certain dose, beyond which the effect comes down. Now, whether there's harm beyond that, we don't know, but the therapeutic effect goes away. So it bears to understand how cellular behaviors really mediate neural tube closure. And this is, there's a pathway called planar cell polarity pathway that refers to the coordinated alignment of cell polarity across tissue planes. And it's not just in neural tube closure, it goes in gastrulation and various developmental systems such as hearing. So a lot of biological processes use this PCP alignment. And what it does, it integrates global directional cues to produce locally polarized cell behavior. What does that mean? It means that it makes these polarized particles, turn a certain way, so that then by definition, the thing folds, the neural tube folds. So this is how this happens on a cellular level. And so that's the same video I showed you earlier. So this coming together is really because of the directionality of these cells. So so there are, again, two genetic factors: one, planar cell polarity, and two, the folate pathway enzymes. But how about the environment? Well, I mentioned that NTDs has both the genetic and non-genetic factors. In this context, it's really important to tell you that we don't think of neural tube defects as a folate deficiency disorder. Folate deficiency, adds to it, and it's a major risk factor for it. But it only happens, as far as we know, in the setting of a predisposing genotype that is already in the human being. Now, if you look at some of the folate enzymes, the MTHFR enzyme, for example, about 25 to 40% of the American population has a mutation, and it's called the C6777T position of MTHFR enzyme. And 3 to 5% of these are homozygous. Now, imagine if this child was given an antifolate, and so you end up adding insult to injury, and you have a major problem. And in fact, one of our friends, Kirk Hogan, published a New England Journal article years ago, and a child that ended up having 2 15-minute nitrous oxide anesthetics for a minor procedure and died. She had an MTHFR mutation, and nitrous oxide is an inhibitor of one of the folate enzymes. So we have to be careful. Antibiotics, trimethoprim, which is in Bactrim. These kids have UTIs all the time. Imagine that someone who's high risk is given antifolates. They're going to have potentially a major reaction. And these environmental contributions are many. So it includes diabetes, anticonvulsants, obesity, certain toxins. So there's a lot to be discussed. So significant progress has been made in the management of spina bifida in the past few decades, both clinical and research. These include improvement in hydrocephalus, Chiari management, prenatal repair, multidisciplinary care through multidisciplinary clinic, which is really a godsend. And scientifically, folate supplementation has been a major success, and there's been identification of several environmental risk factors to avoid. What are the goals? Well, in the future, we look forward to improving prenatal care, prenatal diagnosis, prenatal treatment, as we discussed before. In science, we want to unveil how optimal folate dose and schedule, as well as food fortification, could really clarify the correlation between what we see in animals, what we see in humans, and maybe improve our outcomes. And functionally, we hope that a combination of maybe biomedical prosthetic devices and nerve transfer techniques, like what Angad and we do with, for example, the brachial plexus. There are potentially nerve transfer techniques that can be adapted to the legs, associated with maybe prosthetic devices. I think that's where the future is in terms of functional outcomes. So, to the residents, those who are interested in pediatrics, but also those who are going to the community and have to really take care of some of these patients, I would say really what makes a successful program is introduction of a prenatal clinic, of a multidisciplinary clinic, developing specific protocols with the NICU, developing algorithms for care. When do you do an ETV-CPC? When do you do prenatal repair? And a tailored transition of care program, which we'll talk about in a second. And as pediatric neurosurgeons, like I said before, we really consider ourselves the PCP of the patient. And we have to, because these issues are poorly understood by pediatricians, and there's no way they can understand them because it's an ever-dynamic process that they have to keep track of with many patients, not just with one or two in your practice. So we embrace the social aspect of it and use it as a teaching opportunity. Now, a major current challenge now is transition of care to adult. And the reason I'm saying this is because the majority of surviving spina bifida patients now are adults. The reason you see me do more adult work now than I used to is because these patients need care. And they need very specific care that many adult institutions cannot afford or don't have the expertise. I mean, if you don't see a lot of them, you're not going to have this expertise. So there have been moves, for example, at UAB, Brandon and Jeff Blount have come up with transitional care programs for the kids. You know, at age 12, you do this, at age 15, you do that, at age 18, you do this. But the problem is once they become adults, who takes care of them? And I'm not just talking neurosurgeon, which urologist takes care of them, which rehab physician takes care of them, which orthopedic surgeon takes care of them. It's a major challenge. And it's something that now is probably the number one question, number one clinical challenge that we're facing in our community. How do we give the adults with spina bifida the same care that we've been giving now for 18 years? And who gives it? So anyway, so the myelomalignancy is really the quintessential anomaly that helped shape our field, pediatric neurosurgery, into the specialty it is today. And starting with a few rogue individuals that split away from the adult neurosurgery field, formed the pediatric neurosurgery community and started to come up with what defines them. The requiring an understanding of embryology and science. Central to pediatric science is prevention, of course, the recognition of the effect of folic acid on NTD prevention, which is arguably the most important neuroepigenetic intervention in the past few decades. Spina bifida, of course, includes multiple neurological, congenital anomalies that affect function of many systems, benefiting from long-term multidisciplinary care in partnership with patient advocacy groups like the Spina Bifida Association. And of course, This care requires complex congenital fetal surgery, comprises age and severity dependent diagnostic dilemmas, and really no other anomaly illustrates what we as pediatric neurosurgeons do better than this one. No other helped shape the field as this one has. So I'll end with a thank you for the kids we cared for, the people who helped me with this presentation, and I'll take questions. Thank you.
It's fascinating just to see how the world changes. Patients don't, but our impression of them, or what we can do, what we gave up on, what we don't give up on, it's, for me, very hopeful.
And the patient's understanding has changed too. I mean, they come demanding the best of care. That's really key.
Benny, I'm curious, places like, I don't know, the Scandinavian countries where there's excellent prenatal care, if you can optimize the health of the mother as best as you can, what is the incidence of spina bifida? Do we have some gestalt? Is it as low as it can ever be? I know you mentioned only 70% of defects will be reversed by folate.
Yeah. You know, it's a great question, Raheel. The issue is that the environmental factors are poorly understood. We know certain environmental factors that definitely make a difference. We just don't know many. Why is it that certain areas in England are endemic? You know, more than Africa, for example. Why is it that some are inherited in families and others not? And I think that the problem with the field and introducing folate supplementation in the 80s is that if you look at, you know, the literature behind folate supplementation, huge trial from China in New England Journal, huge trial in JAMA, huge trial in Lancet. I mean, these are not, you know, studies you can't believe. It's obviously there. So that started in the 1980s. How many studies have taken place that showed why this happens? Zero. We still don't know after 40 years. Now, if you were to file an NIH grant and say, I'm going to do this huge clinical trial, but I have no science behind it, what would they tell you? So this is what's been happening. And the problem is that it can't be in isolation. You have to take all these environmental factors into consideration, which means that you have to go back to these countries and say, okay, what is this? What's making the difference here versus there? You have to study their genetics. You have to study their epigenetics, and you know. So Reed and I and Seema's been coordinating this, starting to look at DNA methylation and the spina bifida patients, because we think that any familial disorder that does not have an obvious genetic basis and where it has environmental factors has to have an epigenetic component. And people have not looked at that. So there's a lot that should have been studied 30 years ago that we're just scratching the surface on now.